Hello everyone, I'm Dr. Deepthi and today we'll be discussing some very high yielding topics from which AIIMS people have been consistently asking something or the other in their exams, right? And these would probably have a lot of potential MCQs as well this year for mid-year exams, right? So we're going to focus around these topics which are important, right? Now, let's look at the first one. The first topic that I want you to know is that we would definitely ask something is Down syndrome. Right, so when you talk about Down syndrome, most of the times these central institutes, whether it is AIIMS, PGI, or even JIPMA for that matter, would ask you about the screening programs, right? So please remember that screening should be offered to all pregnant women, right? So we would offer screening to all pregnant women. And in the first trimester, we can do ultrasound for nuchal translucency, and we can do the maternal serum markers. Okay, right? Or you could do both of these. So when you do ultrasound for NT, this is what you need to know about it, that this should be ideally done between 11 to 13 plus 6 weeks, right? And when you are taking this, the plane in which you're going to take the section has to be the sagittal plane. Right, it has to be a strict sagittal plane. The markings that you will take are going to be from inner to inner margin. Right, so they are going to be from the inner to the inner margin, and the head of the baby should be in the neutral position. So not an extension and not an flexion. The head should be in the neutral position, and you should take the markings at the widest position. Right, so at the widest portion of the translucency, you should take the reading, and you should take multiple readings, right, and then take the average, right? So these are some of the things that you have to keep in mind. Also remember that when we are measuring NT, we would keep the head and neck and thorax region of the baby enlarged. So we would keep it enlarged so that you can take the reading easily, right? And this is the picture of nuchal translucency, right? So on the left, it shows that normally also there could be a small collection, but here you see there is a much wider connection. So when this is more than or equal to 3 mm, we say it is a positive screening test, right? On the other hand, I just want you to compare it to the other translucency that you're seeing here, which is actually too big a collection. And, not just too big, if you see, it's extending along the entire spine. And if you can see, it also has septae, right? So if it extends along entire spine, it has septae, it's too large a collection, then it is not nuchal translucency, and this is rather a cystic hygroma. Remember that both cystic hygroma and nuchal translucency are markers for aneuploidy, right? So they're markers for aneuploidy, but the risk of aneuploidy is higher with cystic hygroma than with NT, right? So the risk is higher with cystic hygroma, okay? Now please remember, when we say in the first trimester, we can also do maternal serum markers. The two that we do are HCG and PAP-A. Okay, and the positive test would be when HCG is more than normal while PAP-A is less than normal, right? Now, if you do both, which is ultrasound for NT along with the HCG plus PAP-A, which is called as the dual test. So if you do both of these, then this is what is now called as a combined test. So combined test is also done in the first trimester, okay? Then in the second trimester, the test that we usually do is a quadruple test, also simply called as the quad test, right? So the quadruple test, and it can be done anywhere between 15 to 22 weeks, right? And the quad test is called so because it has 4 components. So we would be doing the HCG, then alpha fetoprotein, unconjugated estriol, and inhibin A. Right, so HCG will be more, inhibin A will be more, while AFP and UE3 are less. Right, so this is what is a quad test. In the second trimester, you can also do an ultrasound at the same time between 15 to 20 weeks to look for soft markers of Downs. Right, and the two most important soft markers for Downs are absent or hypoplastic nasal bone, right? And the other is nuchal fold thickness, which is very different from nuchal translucency. So for the nuchal fold thickness, you say that it should be more than or equal to 6 mm to be positive screening, right? So these are ultrasound soft markers for Downs, which are valuable only when you do it with the, the quadruple test, right? Please remember, when you do all the tests that we have mentioned so far, which means you will do ultrasound for NT, plus you will do a dual test, plus you also do a quadruple test. This is now what is called as a integrated test. So just be sure of these names. Your exams are using these names quite a lot. So this is now what is called as a integrated test, right? Remember, there is one more second trimester test which is no longer done, but yes, you should know that it can be done, is what is the triple test. So triple test can also be done in the second trimester between 15 to 22 weeks, and it doesn't have inhibin A. So these are HCG, alpha fetoprotein and UE3. Right? The findings remain the same, that UE3 and alpha fetoprotein are less while HCG is more. So this is what is the triple test. Remember that this is also called as the BART test, right? No longer done because we see that the quadruple test actually has a higher predictive value. So what we do is a quadruple test in the second trimester, but you should know that it can be a triple test as well. Okay? Right. And please remember, anybody who turns out to be screen positive, right, can either go for confirmatory test, which is what is karyotyping, or can also go for NIPT, right, which is nothing but the non-invasive prenatal test, right? So non-invasive prenatal test or confirmatory test, both can be done if the patient is screen positive. The confirmatory test is karyotyping. So depending on when do you want to do it. So for example, if you want to do it in the first trimester, you will have to do chorionic villus sampling to get the tissue. Whereas if you want to do it in the second trimester, we will do amniocentesis. Okay. Remember that the NIPT test is also called as cell-free fetal DNA test, because that's what you're going to get from the maternal blood sample. So you're going to take a maternal blood sample which is going to have the cell-free fetal DNA, and from this you would be doing the testing, right? So that is what is NIPT. Remember, NIPT can be done anytime at and beyond 10 weeks, right? So it can be done anytime at and beyond 10 weeks, and currently it is only available for trisomy 13, 18, 21 and monosomy X. It doesn't give you a complete karyotype. Remember, it's currently being used as a secondary screening test, which means once the first screening test is positive, then you do this. Please remember that it's not a confirmatory test. So in case cell-free fetal DNA turns out to be positive, now the patient has to definitely go in for karyotyping, right? So these are all the tests that are available for Down syndrome, and then that you should know. As I said, they are definitely going to ask you something or the other from it. Okay. Let's go on to the second set. So as you can see, these are congenital anomalies here. So on the left is anencephaly, right, with the frog eye sign. So the prominent eyes here are the frog eye sign, whereas the other one is anencephaly plus an open spina bifida, right? So this is what is craniorachisis, right? So craniorachisis, an anencephaly along with an open spina bifida. I also want you to look at these two signs of spina bifida. So one is the banana sign, where you see a banana shaped cerebellum. The other is the lemon sign, right, which is the concavity in the frontal bones. So these are also signs of open spina bifida, right? And they could also be seen with, apart from spina bifida, they can also be seen in Arnold-Chiari syndrome, right, or Chiari type 2 syndrome, right? Now, when you talk about gross congenital anomalies and whenever you see them, what should you work out the patient for? So yes, you should look out for aneuploidy in these babies, right? And the second important thing is that you should look out for maternal diabetes, right? So two important things when you see gross congenital anomalies are looking for aneuploidy, right, and maternal diabetes, right? Now, before I go on to talking about maternal diabetes here, because we've already talked about aneuploidy, I would want you to know that when do you usually pick up congenital anomalies? So most of the times we would pick up anomalies on the anomaly scan, yes, which is also called as a level 2 ultrasound. And this is done between 18 to 20 weeks, although it can be done definitely up to 22 weeks, but this is when we would usually do it. Okay. Now, this is going to pick up the gross congenital anomalies, and please remember that the anomaly scan should be done for all pregnant women, right? So it's not just done in diabetes, it should be done for all pregnant women, right? Now, when you talk about diabetes, yes, they have an increased risk of gross congenital anomalies, especially if the diabetes is uncontrolled, right? So in uncontrolled diabetes, they have a higher risk of gross congenital anomalies. The risk is 3 times higher, okay, as compared to non-diabetic women. So we usually say diabetes which is associated with anomalies is overt diabetes, and usually you would not see gross anomalies in gestational diabetes. The reason being that in gestational diabetes you will there is no hyperglycemia during the period of embryogenesis. So the cause of these anomalies is hyperglycemia, right, which is actually fetotoxic, right, and which is not there in gestational diabetes. Now, please remember, when we talk about congenital anomalies in a woman with diabetes, in general, this is what we say. We say that the most common anomaly is going to be cardiovascular anomalies, the second most common being neural tube defects, right? In diabetes, we're talking about diabetes in pregnancy, right? While if we talk about the most specific one, right, this is going to be sacral agenesis, right? Also called as caudal regression syndrome, right? And I'm sure you would know by now that within the cardiovascular system, the most common anomaly that we see in diabetes is going to be VSD, whereas the most specific anomaly is going to be TGA, right? Transposition of the great vessels. Also, now when we're talking about diabetes and we're talking about overt and gestational, and we're talking about the risk of anomalies, you should also know that the risk of anomalies, is ascertained by HbA1c levels. So higher the levels, the higher will be the risk. For example, we say at less than 6.5, there is no risk. But once the value keeps rising beyond 6.5, the risk keeps increasing. For example, at 9% HbA1c, the risk is almost 15%, which is very, very high. So this is for risk assessment. Right? Now, since a lot of things are dependent on the type of diabetes, we should know what is overt. So in order to say that the woman has overt diabetes in pregnancy, either her fasting blood sugar should be more than or equal to 126 milligram per deciliter, or 2-hour PP value should be more than or equal to 200 milligram per deciliter, or we say HbA1c should be more than or equal to 6.5. These are all the criteria to say that the woman has overt, right? One more criteria for overt is when you are doing a 2-hour OGTT test, right? And in this test, the 2-hour value turns out to be more than or equal to 200. So in the 2-hour OGTT, if the value turns out to be more than or equal to 200, then that is also going to be overt diabetes. For gestational, so which is what is seen with the DIPSI test, or also called as 2-hour OGTT test, right? Please remember, for this test, the woman does not need to be fasting, right? So you are going to do this test irrespective of her last meal. So whenever the patient comes to you, that is the first time of the testing has to be the first antenatal checkup. So whenever she comes for her first antenatal checkup, as per our national guidelines, we should now be ordering a 2-hour OGTT, where what we do is first give her a 75-gram oral glucose, right? And then you're going to withdraw the sample after 2 hours. If the value is more than or equal to 140, then this is what is GDM, right? But if this value turns out to be more than or equal to 200, then as I have said before, that this will rather be labeled as overt diabetes, right? So that's what we follow in the 2-hour OGTT test, okay? Also, since, they have been asking something or the other about diabetes, so it could be anomalies, it could be how you make a diagnosis. And the other thing that you should know here is that, in diabetes, the babies tend to be macrosomic, right? And most of the morbidity of the fetus depends on whether the baby has macrosomia or not, right? The criteria for macrosomia is more than or equal to 4 kg of estimated baby weight. Yes. So if it is like this, it is macrosomia. Now, what I want you to know is, how do we decide when to terminate the pregnancy? So please remember, baby weight is no criteria on when to terminate the pregnancy. In diabetes, as long as it is well controlled, and it doesn't matter on what it is well controlled, whether it is diet, or whether it is insulin, or whether it is oral drugs. So if it is well controlled, then the patient has to be delivered at and beyond 39 weeks. Yes, we may take the pregnancy up to 40 weeks, but we would not want to go beyond EDD, right? But for sure, definitely not less than 39 if it is a well-controlled diabetes. For uncontrolled diabetes, we can't give you a one particular gestational age because it depends on the findings of the patient, right? And what kind of damage is it causing to the patient, right? So then we don't have any specific values. But for well-controlled, we do have specific values, okay? Then also, when it comes to, diabetes, we should be knowing that especially in a woman with GDM, right, the initial thing that we do for her is a diabetic diet, right? So we put her on a diabetic diet for 2 weeks, and then we will decide whether she needs the medication or not. So you should know when would we start the medication. So if on diabetic diet, her 2-hour PP is more than or equal to 120, that's when we're going to start her on medication. And for medication, we say insulin is generally the drug of choice, right? So insulin is generally the drug of choice for this, right? And yes, once you talk about termination, as I told you, that POG doesn't depend on weight, but yes, definitely how you will deliver her depends on weight, which means if the estimated baby weight in a diabetic pregnancy is more than or equal to 4.5, then this is an indication to do a cesarean. Otherwise, they can very well be delivered by a vaginal delivery, okay? And one more thing that the AIIMS people are very fond of asking is when the baby has gross congenital anomalies, especially the neural tube defects, what should we do to the dose of folic acid? So please remember, if there is a previous history of neural tube defects, yes, the dose of folic acid that the patient has to receive is 4 milligrams. Right, 4 milligrams. And the minimum requirement is that it should be started 3 months before pregnancy to 3 months after conception, right? That's what is the requirement. But yes, since this is very theoretical, ideally what we would do is whenever the patient presents to us preconceptionally. So ideally, because, to know when exactly she would be pregnant, it's quite impossible. So what we are going to follow, or a better answer than this will be, whenever she presents preconceptionally, okay? Because that way you are reducing the risk. Otherwise, she will be pregnant and then come to you after that. So therefore, we say ideally whenever she presents preconceptionally, right? Okay. Then please remember, do not confuse it with the dose of folic acid, which we give routinely to all pregnant women. So all pregnant women, including diabetic women, okay? All pregnant women, including diabetic women, would also need folic acid, but the dose here that we give for prophylaxis of NTD. Now be careful, this is how they can confuse you. This is simply prophylaxis of neural tube defect, whereas what is that? The one that we discussed is 4 milligrams. This is prophylaxis for recurrence of neural tube defect, right? So this is prophylaxis for the recurrence of neural tube defect. So the words are almost similar, so don't get confused, right? So 0.4 milligram is what you give to all pregnant women, including diabetic women, and the requirement is 1 month before conception to 3 months after conception, right? That's what is going to be the dose. Right, so folic acid, as I said, has been quite a consistent question with AIIMS people previously. Okay, now also, typically I showed you anencephaly and craniorachis. They've been asking things about it. Remember the basic things, that anencephaly can be picked up on ultrasound earliest at 10 weeks. So this anomaly is the earliest anomaly that can be picked up on ultrasound, and it's picked up by 10 weeks. Okay, but the ideal time to pick up anencephaly is 14 weeks and beyond, right? That's the ideal time, is 14 weeks, but it can be picked up as early as 10 weeks. Okay, right. So the next set of things that I want to discuss, that again the central institutes and again AIIMS and PGI are very fond of asking, are things about molar pregnancy, right? So this is what is the grape-like vesicles of molar, right? This is the snowstorm appearance, right? And this is the cannonball, right? So now remember this, that grape-like vesicles as well as snowstorm appearance on ultrasound of the uterus are very characteristic to complete mole, right? These findings are characteristic to complete mole. They are not seen with partial mole. Things that I want you to know about complete mole are that they have 80% of times a karyotype of 46XX, and they are usually monospermic, right? And all the genetic material that they have is paternal, right? So all the genetic material is paternal, right? And as I said, grape-like vesicles in snowstorm is also unique to complete mole, right? Apart from this, there is no fetus in a complete mole, and the HCG values are going to be very, very high, usually more than 10 to the power 5, and the size of the uterus is bigger than POG. Also unique on the ultrasound of complete mole is theca lutein cyst in the ovaries, right? So theca lutein cyst in the ovaries is again quite unique to complete moles, right? On the same note, just to put out the differences for you for a partial mole. Partial moles are 90% of times triploid, and they have a karyotype of XXY. They are dispermic, right? And the extra set of chromosome here comes from the father, right? A fetal tissue is always present, but what you have to know is that because it is triploid, is usually non-viable. It will have multiple gross anomalies. The HCG here is definitely more than expected, but not as high as 10 to the power 5 and beyond. The uterine size is usually smaller than the POG. Sometimes it may be equal to the POG, but not more than the period of gestation. Theca lutein cysts are not seen in partial moles, right? So those are the comparative things. Also, since I said the PGI people are also wanting to ask these questions from you, remember I said complete moles are 80% of times 46XX, but yes, the remaining 20% of these can be 46XY, and it is these XY ones which are going to be dispermic, right? They're going to be dispermic. Now, why do we want you to see the cannonball? Because the complete moles have a high risk of conversion to GTN. So if you look at the risk of complete mole into GTN, it is 15 to 20%. And the risk of conversion of complete mole typically to choriocarcinoma is around 4%, right? And cannonball metastasis is the most common site, or lungs is the most common site of metastasis, right, of choriocarcinoma, and the characteristic appearance is cannonball. That's why we wanted to show you the cannonball. Please remember the second common site is vagina, where you will see it as a suburethral nodule, right? Now please remember, when you talk about a a complete mole converting into choriocarcinoma. Apart from these things, we first want you to know who are the patients who are high risk for this conversion, either into GTN or into choriocarcinoma. So these are women who are more than 40 years of age, right? These are women whose HCG is more than 10 to the power 5. These are the women where the uterine size is more than the POG, right? And these are the women which have bilateral large theca lutein cyst, okay, right, which are more than 6 centimeters. So these are the high risk women who are going to convert into GTN, all right? Now, apart from this, you should know that if they do convert into GTN, they can present in multiple ways. So one of which was metastasis, and we've already discussed that. How else can a woman present if she has converted, if you typically talk about choriocarcinoma? So if she's converted from complete mole to choriocarcinoma, she may present to you with metastasis. She may present to you with continued bleeding even after suction and evacuation. She may present with a uterine subinvolution, which means the uterus remains enlarged and it does not go back to the pre-pregnant size. It may present with rising serum HCG, right? So she may also present with a rising serum HCG. So these are the various ways in which these women can present, typically if they have converted into choriocarcinoma. Remember, choriocarcinoma is a very, very chemosensitive tumor. So even if it has shown a metastasis like to the lungs, which is characterized as stage 3 GTN, she still has good prognosis, right? So despite the fact that it's stage 3, it is still good prognosis. The PGI people are quite fond of asking you poor prognostic markers for GTN, right? So these are, number 1, if the age is more than 40 years, right? Second, if the HCG is more than 10 to the power 5. Third, if the antecedent pregnancy was a full-term pregnancy, right? Fourth, if you have made a diagnosis of choriocarcinoma beyond 12 months from the antecedent pregnancy, right? If you are seeing metastasis to brain or liver, and if you are, or if the patient was a previous case who's received multi-agent chemotherapy. So if she has previously received multi-agent chemotherapy and still she has shown a recurrence, it's going to be poor prognosis. So these are all poor prognosis markers for GTN, which again your exams are very fond of asking, right? So these are some typical questions that we would ask. I'm not discussing very basic things like what is the treatment of choice for molar. You all know that it is going to be suction and evacuation, irrespective of the size of the uterus. What do you do for theca lutein cyst? Nothing. So all you have to do is suction evacuation of the mole, and the theca lutein cyst will disappear usually within 2 to 4 months, right? So normally these theca lutein cysts are going to disappear, but if they persist, then it again indicates conversion to neoplasia. So we can add that as well into the factors where we have written how can they present if they convert into GTN. So they can present also with persistent theca lutein cyst, right? Please remember the period of surveillance for molar pregnancy is 6 months, while the period of surveillance for neoplasia is 12 months. And the most important advice during this time for my patient is that she should not conceive, and therefore we will say that the contraception of choice in these women is OCPs. Please remember that's the contraception of choice. Definitely barrier is safe, but because it has a high failure rate, we say contraception of choice is OCP. And then also remember the one contraception that you should usually avoid is an intrauterine device. So avoid IUDs, and the best is combined oral contraceptive pills. Okay, right. The next sort of things that your exams are fond of asking again in some form or the other is twin pregnancy or something related to it, right? So this here you see is the lambda sign, while the other one that you see here is the T sign, right? Important because lambda is a marker of dichorionicity and T sign is a marker of monochorionicity, and we want to know whether the fetus are monochorionic or dichorionic, because in general monochorionic have higher risk as compared to dichorionic, right? So a lot of times in your exams you want to know whether the pregnancy is monochorionic or dichorionic. So the best way to look for this is on the ultrasound, right? This ultrasound should be preferably done in the first trimester and preferably done beyond 7 weeks. The best time to do it is around 10 weeks, right? Now, yes, so that's when you will see the lambda sign, but what are the better signs to say that it is dichorionic? So the best signs to see that it is dichorionic is either if you see 2 separate placenta, right, or you see opposite sex twins, right? So lambda sign is definitely a sign of dichorionicity, but that's not the best sign. So we are saying that the best signs have to be either seeing 2 separate placentas or opposite sex twins. Remember, the lambda sign is also called as twin peak sign, and as I said, the best time to see this is at 10 weeks. The range is 10 to 14, but the best time to see it is 10 weeks, right? The other things are, if you see the number of dividing layers, there will be 4 dividing layers, right, between the 2 twins. So which is going to be 1 chorion and 1 amnion of one baby and the other chorion and other amnion of the other baby. And if you cannot count really the number of layers, then what you should see is the thickness of the dividing membrane, right? So if this thickness is more than 2 mm, right, then we definitely say it's dichorionic, right? So these are some of the ways to say whether it is dichorionic or monochorionic, right? The other important way could be asking you same question in terms of the placentas, right? And that's what we want to focus on now. So whenever you get an image of placenta and you have to comment on chorionicity, this is what you should know. The first thing that you have to see is, do you see a dividing groove between the 2 umbilical cords? Yes, for example, there is a dividing groove in the first figure. There is also a dividing groove between the 2 cords in the second figure. But if you see in the third, there is no groove between the 2 cords. Yes, do you appreciate that? Whenever there is no groove in between the 2 cords, this is automatically monoamniotic and therefore definitely monochorionic. So this would be monochorionic and monoamniotic. Now, when the groove is present, then it's definitely diamniotic. So figure 1 and 2 are both diamniotic, but now we have to comment on the chorionicity, right? So if you see that the groove is thin, like in figure 2, right? If it looks thin, then it is monochorionic diamniotic. Whereas if it looks thick as in figure 1, then it is dichorionic diamniotic. The second thing to pick it up is that, do you see there are no vascular connections in the first figure between the 2 umbilical cords? Whereas there is definitely, you can easily appreciate the vascular connections in the second image. So when it is thin, so the dividing membrane is thin and there are vascular connections, it is monochorionic. When the dividing membrane is thick and there are no vascular connections, it is dichorionic. Right, that's how we're going to comment on chorionicity and amniosity, by looking at the placentas, right? Also, please remember that the same thing can again be asked in a third format, which is the timing from cell division. So if the embryo or if the conceptus divides within 3 days of fertilization, right? So if the division of the conceptus happens within 3 days of fertilization, which means in the stage of morula, then the type of twins formed are dichorionic and diamniotic. If the division takes place between the 4th and the 8th day, which is in the stage of blastocyst, right, then it is going to be monochorionic and diamniotic, right? Then it's going to be monochorionic and diamniotic. Now, once the division takes place when the embryonic disc is formed, so if the embryonic disc is formed, which is going to be beyond 8 days, then they are monoamniotic. So between 8 to 12 days, it's monoamniotic and naturally monochorionic, right? And when the division happens beyond the formation of the embryonic disc and the division is not complete, so they are going to be joined by some point. So beyond 12 weeks, it is going to be conjoined twins, right? So beyond embryonic disc, it can be monochorionic monoamniotic, or it can be conjoined, depending on whether they are joined at some point or not. That's yet another way of commenting on chorionicity and amniosity. Please remember, in general, the most common type of twins are dizygotic. So 70% of times it's dizygotic, and therefore in general the most common type of twins are dichorionic and diamniotic. But when we talk about most common type of monozygotic twins, then it is actually monochorionic and diamniotic, right? Also remember that dizygotic twins, their incidence throughout the world keeps changing or is variable, whereas the incidence of monozygotic twins throughout the world is constant. They do not change. So they are not, which means in other words, their incidence is not dependent on race or on ethnicity or on family history, right? Right, and the last thing about the twins, please remember the most characteristic complication of monochorionic twins. Right, so most characteristic for monochorionic twins is twin-twin transfusion syndrome, while most characteristic for monoamniotic twins is cord entanglement. Okay, right. Let's look at the next set of things that these people are fond of asking. So again, you're getting quite a lot of questions on placenta and abnormalities, right? So just remember to identify these. So here you see an extra lobe attached to the main lobe. So this is a succenturiata, right? This one is a battledore placenta, because what you see is the cord attached to the periphery, right? Otherwise the cord is attached to the center of the placenta on the fetal side, right? This one is a velamentous placenta, or velamentous cord insertion, right, where the umbilical cord has finished way before the placental tissue and the vessels are traveling outside the cord. Okay, and this one that you see here, so what you see is that the chorionic plate is smaller than the basal plate. This is the first thing that you should identify. Chorionic plate is smaller, and the junction of the chorionic plate and the basal plate can be seen by this rolled out or raised margin, right? So when you see this raised margin between the chorionic plate and the basal plate, this is called as circumvallate. So even the JIPMA people are fond of asking these. So you should remember, when you see a raised margin and the chorionic plate is smaller, is circumvallate. If the chorionic plate is smaller but there are no raised margins, so it is a smooth transition between the chorionic plate and the basal plate. So chorionic plate will still be smaller but no raised edges. Okay, then this is what is called as circummarginate placenta. Right, remember that battledore and succenturiata can cause postpartum hemorrhage, right, when this additional lobe is left behind, whereas velamentous is rather associated with antepartum hemorrhage, right? So velamentous is associated with antepartum hemorrhage, while succenturiata is associated with postpartum hemorrhage. The moment I say that, I would go on to yet another topic that the AIIMS people as well as all other central institutes are also fond of asking, and that is AMTSL. Right, so active management of third stage of labor for PPH, which is for prophylaxis of PPH. Right, so you should remember that the most important component is giving the uterotonic agent, right, which should be given within 1 minute of delivery. Right, now here we have written uterotonic agent. Remember, the drug of choice is oxytocin. Okay, it can be given IM bolus or IV infusion. So IV has to be an infusion, not an IV bolus. Although the drug of choice is oxytocin and you give 10 international units, the other drugs that can be given are methergin, right, or methyl argometerine, right? Then carbetocin, which is a synthetic oxytocin analog, as well as misoprostol, right? And the high risk patients can also additionally, apart from uterotonic, can also receive Trenexa. So Trenexa is not an alternative, it is an add-on therapy to high risk patients, right? So tranexamic acid, which is nothing but a antifibrinolytic drug. It is not a uterotonic. It's an add-on in high risk patients. Okay. The dose of methergin is 0.2 milligrams IM. Carbetocin is 100 micrograms IV, and misoprostol is supposed to be taken as 600 micrograms per oral. That's what is the WHO recommendation. Okay. Then please remember, as a universal guideline for AMT-SL, what is supposed to be done is delayed cord clamping, right? With only exceptions where you would do early is for India, HIV positive, right? If the baby needs resuscitation, or if the pregnancy is Rh negative. These are the conditions where we would do early, right? Otherwise, we would do a delayed cord clamping as a universal recommendation. The delivery of placenta has to be done by a controlled cord traction method, right? And please remember, uterine massage is not a routine component. It is routinely not recommended by WHO because we are routinely giving a uterotonic. Massage is not required to be done, right? So uterine massage is routinely not recommended. Okay, what you're supposed to do is intermittent uterine tone assessment, right, where we will assess the tone of the fundus every 15 minutes for a span of 2 hours, right? So that is what is intermittent uterine tone assessment. So it's not massage. In case we are asking you, all are components of AMT-SL except, and one option is early cord clamping, right, while the other is uterine massage. So what is the problem is that both are incorrect, right? So the question is, all are components of AMT-SL except, both are wrong. But if ever that is a confusion, you should always stick to marking early cord clamping, right? So then you should mark early cord clamping. This is a better answer as compared to uterine massage. Okay, please remember, for management of PPH, right, especially we would ask you about the atonic one. So again, the drug of choice is oxytocin, right? But if the patient is not responsive to this, right, then the next agent has to be either methergin or it has to be carboprost, right? And this drug method that we are using, it should be done for a maximum of 30 minutes. If in 30 minutes these drugs are not acting, then you go on to the next method, which is going to be balloon tamponade, right? So then it is going to be a balloon tamponade, and the balloon is filled with 500 ml of normal saline or ringalactate, right? Now please remember, again, misoprost can be used here, but it's not the drug of choice. It's not an alternative. It is only to be given when IV and IM drugs cannot be used. And for treatment of PPH, the dose is 800 micrograms sublingual as recommended by the WHO. In case we are giving per rectal, which WHO says can be used as an alternative, so recommendation is sublingual, but if you are using it per rectally, you can go up to 1000 micrograms. So 800 to 1000 micrograms per rectally, right? So those are important things about PPH and placenta that these exams are fond of asking. Right, the next set of things are questions that they're fond of asking about abortion, typically PGI as well as AIIMS, right? So AIIMS would usually ask about recurrent abortions or recurrent pregnancy loss, while PGI would generally ask anything about abortions, right? Now please remember, when it comes to recurrent pregnancy loss, there are only 4 established causes, and only for these established causes you will sort of investigate the woman. So these are APLA, investigate her for uterine causes, then investigate her for hypothyroidism, okay, hypothyroidism, and yes, investigate her for chromosomal anomalies, right? So this is also in the order as to what is the leading cause. The leading cause is APLA amongst the established causes, then comes uterine causes, then comes thyroid dysfunction, and then comes chromosomal. Right? So this is what you're going to investigate the woman for. Remember, infections do not cause RPL. That's the general take-home message. Infections do not cause RPL. Please stick to this order and stick to this table, whether they ask you causes of RPL in the first trimester or they ask you causes in the second trimester. You're going to stick to these 4 established causes in the order that we've written them, right? On the other hand, when you talk about in general about abortions, right, and not specifying recurrent abortions, then the answer of most common cause is chromosomal. Now, chromosomal is a big group, and within the group, the most common cause of is aneuploidy, which is responsible for 50% of the abortions, right? And what you need to know is that within aneuploidy, the most common is trisomy, because it's a group, right? But if your exam asks you single most common cause, which is again an aneuploidy, but then the answer changes. For single most common cause, it is to be answered as Turner's. And if Turner's is not in the options, then trisomy 16, right? The PGI people are also fond of asking you which is the most viable trisomy and non-viable. So remember, trisomy 16 is the most non-viable trisomy, right? So most non-viable trisomy is trisomy 16, whereas the most viable trisomy is trisomy 21. Trisomy 21 is also in general the most common trisomy, right? Also, when it comes to abortions, and we're talking about recurrent abortions, remember in the uterine causes, an important cause is cervical incompetence, which is what I had shown the image for. So this is a procedure that you do for cervical incompetence, okay? And this is a cerclage, right? Now, please remember, cervical cerclage is not only done for cervical incompetence, but it can also be done for or as prophylaxis of preterm labor in women with short cervix. So you can also put this cerclage for prevention of preterm labor in women who have a short cervix, right? And I hope you all already know the criteria for short cervix, which is cervical length less than or equal to 2.5 centimeters or 25 mm, right? And the ideal time to look for cervical incompetence is going to be in the second trimester. Right, in the second trimester. Normally, in women who are, or all pregnant women, we would look for cervical length in the second trimester in the level 2 scan, which is done at 18 to 20 weeks. But in women who have history of preterm labor, we can start doing or following up the cervical length much earlier, say around 14 weeks, right? And please remember, the most important risk factor for preterm labor itself is previous history of preterm labor, and these women may have a short cervix. So you will start evaluating these women earlier. Also, things that can lead to cervical incompetence are procedures like cervical conization, right? So then also you should be able to follow up these women with the cervical length. What I wanted to show you in the visual is that this is the most common cerclage we do, and this is called as McDonald's stitch or the McDonald's cerclage. As you can see that the stitch is passing through all the walls of the cervix, and it is therefore, because of this unique shape, called as a purse string suture. Right, and the ideal time to put it in a woman with cervical incompetence is 14 weeks, right? So the ideal time to put it is 14 weeks, right? Or whatever the earliest time she comes to us, right? This is also with relation to viable pregnancies, because abortion is a non-viable pregnancy. So these are the two important signs of, early intrauterine pregnancy, right? So if you see these are signs of intrauterine pregnancy. So one is the double decidual sac sign and the other one is the double bleb sign, right? So they are especially early markers of intrauterine pregnancy, the double decidual sac and the double bleb. The amniotic sac, right, and yolk sac, right? So it can be an amniotic sac and the other one is the yolk sac. Please remember the criteria on when you will say it is an abortion or a non-viable pregnancy, right? So first is, if you're seeing a G-sac, measure the mean sac diameter. Okay, a mean sac diameter of more than or equal to 25 mm. But if it has no yolk sac or embryo inside, then this is a non-viable pregnancy, which is called as blighted ovum, right? The second is, if you are seeing a G-sac with an embryo inside, you measure the CRL. So CRL more than or equal to 7 mm and no cardiac activity is also a non-viable pregnancy, which is called as a missed abortion. Please remember, you can't call it non-viable unless these are the values that you see on ultrasound. So if the values are less than this, you'll have to keep repeating the ultrasound unless you reach these values, and only then you can document it as a non-viable pregnancy, right? So this is also the ultrasound definition of abortions of non-viable, and these exams have been trying to ask this in some format or the other, right? The next set of questions is what again the AIIMS people are very fond of asking you, is identifying the type of decelerations on the graph, right? So please remember one very basic thing. If you see a graph like this where there is a quick fall and a quick pickup, this is the first thing you should identify. So if it's a quick fall and a quick pickup, abrupt is the term we use. So if it's an abrupt fall and an abrupt pickup, then these are variable decelerations, which are because of cord compression. And yes, naturally, the other thing about the variable decelerations is they have no consistency with respect to a contraction. So sometimes they appear before, sometimes they appear after, and sometimes in between the two contractions, right? Now, these may be physiological or they may become pathological. Now, these would be pathological and the clinician would be worried about them in case these are recurrent, or in case the heart rate dips down to very low value of less than 70 beats per minute and it is lasting for whole 60 seconds or 1 minute, right? That's when the variable will become significant or pathological, okay? Right. If you see, on the other hand, a slow fall and a slow pickup, or a gradual fall and a gradual pickup, these cannot be variable. So these will either be early or late. And then to identify whether these are early or late, see whether the contraction is persisting after the contraction, the deceleration is persisting after the contraction or not. Like in this particular graph, it is persisting even when the contraction has stopped. And this would be an example of late deceleration where the cause is uteroplacental insufficiency, right? Whereas if you see that the fall is gradual, slow fall and a slow pickup, but the deceleration disappears after, once the contraction stops, right? So it is completely accompanying the contraction and it doesn't last after the contraction, then this is what is early deceleration, which is because of head compression and is completely physiological. We don't have to worry about it, right? So this is because of head compression of the baby. A typical pattern on NST is a sinusoidal pattern or a sine wave pattern, because simply it resembles the sine wave of physics. So every wave resembles the previous wave. Remember, the cause is severe fetal anemia. That is the best answer for this. If fetal anemia is not in the answer, then you go out and answer it as severe fetal hypoxia, right? And to document whether the baby has anemia or not, we would actually do a MCA Doppler for this. And what we measure in the MCA Doppler is peak systolic velocity, right? A peak systolic velocity of more than or equal to 1.5 multiples of median indicate that there is significant anemia in the baby, which means it is significant to cause heart failure in the baby, right? That's how you pick up anemia, okay? Then important things are about the LICA. So this is a picture which you see with oligohydramnios in the baby, right? So with severe oligohydramnios, there can be a condition called as amniotic band syndrome, right? Which is also called as Streeter's dysplasia, right? And what you have to identify is that these children will develop distal limb amputation. So the arrows here are showing you that the distal limbs are affected and the digits get amputated, by themselves. And what you can see are the constriction rings, right? And this is what is the other picture is also showing you. There is digital amputation. So only distal parts of the limbs are affected. The whole limb will not be absent, distal parts, right? And another thing related to severe oligo you should know is renal agenesis, right? So if there is no urine output, there will be no amniotic fluid as well, right? So when there is renal agenesis, there will be severe oligohydramnios, right? And the important condition that you should know is associated with polyhydramnios are GIT anomalies and neural tube defects. So for example, anencephaly we've seen before is associated with poly. And the main reason for poly here is absent swallowing. So whenever the baby cannot swallow, it will cause poly, whereas whenever the baby cannot pass urine, it is going to cause oligohydramnios. Remember, the amniotic fluid is absolutely clear fluid in the beginning of the pregnancy, and as the pregnancy reaches term, it becomes a little turbid and cloudy, right? So it actually means that the pregnancy is a mature or a term pregnancy, right? And remember that the two methods to measure it are amniotic fluid index and deep vertical pocket. You should know the definitions of poly. Here is more than or equal to 25 and here it is more than 8, while the definition for oligo in AFI is less than or equal to 5 and less than 2 for deep vertical pocket, right? And the absolute volume for poly is 2 liters and for oligo it is 200 ml, right? So these are other things, but it's better to know more details about amniotic fluid. They're asking something or the other. These were applied questions on poly and oligohydramnios, right? Fine. AIIMS has been asking something or the other about some kind of exposure during embryogenesis, right? So this one is actually warfarin and this is alcohol, right? So that's a fetal warfarin syndrome and that is the fetal alcohol syndrome, right? Either they could show you as visuals or they could ask you things about it. With fetal warfarin syndrome, it is most likely to happen if the baby is exposed to warfarin between 6 to 12 weeks. The findings resemble a condition called as chondrodysplasia punctata because it is the cartilage formation which is affected here. And because of the cartilage formation, you see that they have a flat nasal bridge and they have stippled epiphyses, right? And for this reason, do not give warfarin in the first trimester. So we would typically ask you this question with respect to heart disease, and this is what you need to know. At 1 to 12 weeks, if the patient has prosthetic heart valves, right? So in the first 1 to 12 weeks, you should not give warfarin. So here we are going to put her on heparin therapy, right? From 12 weeks to 36 weeks, we are going to put her on warfarin. She is a high-risk patient. She needs a more potent drug. But at 36 weeks, so from 36 weeks to the onset of labor, we are again going to switch her over onto heparin because close to labor, we again do not want to give warfarin, which actually travels through the placenta, reaches the baby, will cause more severe effects on the baby and can also cause postpartum hemorrhage. So that's how you give warfarin. For alcohol syndrome, you should know that there is a triad. There is going to be certain CNS findings, there is going to be facial features, and there is going to be growth restriction, right? So that's the triad of fetal alcohol syndrome, and the typical facial features is what we are trying to show here. So they have short palpebral fissures, right? And they have an absolutely smooth philtrum, right? And they have a very thin upper lip, which is almost looks like a straight line. So that's a thin vermilion border, right? So this is the typical facial feature, while the other one, as we said, is a triad. Okay. Right. Partogram has been something that the AIIMS people have been asking, and okay, this isn't really, it's too bright to be seen here, but this is what you need to know about the partogram, that you start monitoring when the woman goes into active labor, which means on the partogram, and we are still going to follow on the partogram WHO values, which means you start monitoring when she is 4 centimeters dilated. Always start monitoring on the alert line. So you always start monitoring on the alert line. So it has to be on the alert line, right? Then you should know that the time gap between alert line and action line is 4 hours, right? So there will be 4 big squares between them, 4 big squares. So 1 square is equal to 1 hour. You should know that as long as the pregnancy is to the left of alert line or on the alert line, it means it's a normal progress, right? So the slope of the alert line tells us that the progress is normal, and it has a slope of 1 centimeter per hour. Whereas if the graph comes to the right of alert line, right, it means it is slow labor, right? And she needs to be referred to a higher center. Okay. Whereas in case the graph lies on the action line or to the right of action line, right? So on the action line or to the right of action line, it means this patient needs intervention now. So not only is it slow labor, but it also needs intervention. Also, remember that a horizontal line on the partogram, so if it goes like this and then becomes straight horizontal line, represents arrest of cervical dilatation, right? And you will make a diagnosis of arrest of cervical dilatation if there is no change in the cervical dilatation for 4 hours with adequate uterine contractions. That's how we define arrest of labor, or arrest of cervical dilatation, or arrest of active phase. And on the partogram, you will see it like a straight horizontal line, right? So these are some very basic things that we do tend to ask about the partogram. Remember, the partogram would also tell you about the fetus and the maternal condition. So yes, we do record the fetal heart rate, we record about the amniotic fluid, and we record about the molding. In the maternal condition, we are going to record the vitals. Apart from that, the urine output, the temperature of the woman, as well as the uterine contractions and what all drugs she is getting. So all this information about vitals, urine output, her temperature, uterine contractions and drugs would also be getting from the partogram. Okay. They've been usually asking some very basic things, and these are the most likely things that they do tend to ask. Right, that is the last slide for the obstetrics session, right? And this is a Carmen's cannula. Again, they have been asking things about it. So Carmen's cannula is what we use for MTP, right? In the first trimester, in suction and evacuation, which can be done up to 12 weeks, right? But this Carmen's cannula is also used to do a endometrial aspiration cytology in non-pregnant women, right? So we also use it to do endometrial aspirational cytology, right? Or simply put it as endometrial sampling, right? So we are also using it for endometrial sampling in non-pregnant women. In pregnant women, we are using it for MTP. Please also remember that the pressure generated in the suction evacuation is 600 millimeters of mercury. And remember that if you do a perforation with the Carmen's cannula, you have to immediately do a laparoscopy or a laparotomy, which is different from if you do it from a Hagar's dilator. So Hagar's dilator is blunt. So if you do a perf with Hagar's dilator, you only have to sort of wait and watch and monitor the vitals of the woman, right? And suction evacuation we would do for pregnancies which are beyond 7 weeks and up to 12 weeks, right? Then alternative to suction evacuation is MVA, which is what I've tried to show you on the left. The third one is the MVA syringe that we use. So this image simply shows you the older MVA syringes that we were using and the latest one. So this is the one we use. So you should answer, if such a syringe comes, you should answer it as an MVA syringe. It has a capacity of 60 ml and it generates a pressure of 660 millimeters of mercury. If that's not in the answers, it is still 600. Remember that it is an alternative to suction and evacuation, which means MVA can also be done up to 12 weeks, right? And please remember, at less than 7 weeks, what we are going to do is medical outpatient abortion, which is by using Miffy and Miso. It is 200 milligrams of mifepristone given orally, and it is 400 micrograms of Miso, which can be given per vaginally. It can also be given oral, sublingual, or buccal preparations. The most important things, apart from the doses that I've mentioned, is that it is allowed only up to 49 days as per the MTP Act of India. Do not get confused. This is what we follow in India. There is no doubt that WHO does approve it for 9 weeks or 63 days, but this is a law in India and we follow the law of the land, which is 49 days or 7 weeks, right? Any woman who has severe anemia, right, who has an intrauterine device in situ, right, who is a suspected case of ectopic, somebody who is on steroids because she is a case of adrenal failure, someone who is a case of porphyria, and someone who is allergic to these prostaglandins, someone who has a severe cardiac or a liver disease, should not undergo medical outpatient abortion. So these are actually contraindications for medical outpatient abortion, right? So these are some of the most high-yielding topics that we do tend to ask in all these central institutes, right? And I'm sure you will get something or the other from each of these topics in the upcoming exams, right? So make the best use of the obstetrics session, and we have a separate gynae session as well, where I would again cover the important gynecological topics that are asked in the central institutes. Thank you so much and all the best.